Hi, how you doing?
Fine, thank you.
Hey, hey, listen, I'm setting
Yeah.
up a conference in Nepal.
Oh,
Good. Yeah, I'm
yeah, yeah.
setting up a conference in Nepal. I wonder if you could help us set up the sound when we do it.
After this,
Hold on. Uh, well, I'll talk to you after, okay?
yeah, I will.
Okay, because I want to ask you something, but so after we're done, please don't leave, okay?
Yeah, I will.
Okay. Testing 1 2. Testing 1 2. Testing the mic. So Musindo, how's it going? So how you been,
Hello.
Musindo?
I'm fine. I'm here.
Okay, you're in Cameroon, right?
No. I'm in Mozambique.
Oh, Mozambique. Okay, Dr. Kazadi, do you know him?
I know. In lastly for 2 weeks ago.
Well, he's in Mozambique, right?
I'm from Mozambique.
No, but Dr. Kazadi, is he in Mozambique?
I don't know.
Yeah, let me look up. Let me see if he is. No, I'm sorry. He's in Zimbabwe.
Zimbabwe. Okay.
Yeah.
Neighbor from
I get
Mozambique.
confused.
Yeah. I have seen it for you make some confused. Zimbabwe is a neighbor of Mozambique. We are between Zimbabwe, South Africa, Zambia, Tanzania.
Yeah. Okay. Yeah, I get confused with the African geography, especially around the area of the Ivory Coast and Ghana, the countries around there. You know what Ghana is, right?
Ghana. I know has a Africa country.
No. Now you're a medical student, right?
Yeah. No. I am resident.
Oh wow, and you like video platforms, right?
I am resident of neurosurgery in Maputo, Mozambique.
You like video.
Yes, I've seen it.
Yeah, good. Yeah, you will meet many people this way. You met Dr. Sabaya. He's a big educator in neurosurgery in the Arab world.
Okay, from Jordan.
Okay, excuse me for a second. I've got to go to do something. Okay, I'll be right back.
Okay. You know when. Eu sou o único. Não, que eu estou a ver aqui, tenho muitas coisas que eu posso adaptar, né? Então, só que antes eu não estava a ter essa visão, só que hoje, de repente, comecei a ver que não, mas afinal, quando eu só sofri por quê? أنا قال لي ليه أنا apágalo,
Agora você não vai beijar paciente?
apágalo,
Você,
apágalo.
desse jeito você não vai beijar paciente? Ah. Eu vou fazer com o paciente. Onde você vê? Desse jeito.
Assalamu alaikum, Mr. Khair.
Já se
Good evening, everybody. My name is Ibrahim Sweh. I'm a neurosurgeon, and we are transmitting
assim?
live for international audience
Não é
from the
possível.
FRCS campus here in online Jordan. And this is the picture of Dr. Zaid Kilani, the founder and the pioneer of the IVF babies in the Middle East, the founder of this hospital. The topic for tonight is going to be giant invasive pituitary adenomas. So I have two words, giant and invasive, and the two are totally different from each other. I thought at the beginning, I'll take you through the journey of the people who had a great impact on pituitary surgery. And the first of these are the pharaohs, the Egyptian, 5,000 years ago.
No,
This
no es
is
emplear.
Dr. Carter,
Entrar
who
a
discovered
pupila.
the tomb of Tutankhamun in 1923. And he found lots of mummies. This is Dr. Hawass. He is the Egyptologist who is doing CT scan for the mummies. And they found that the brain inside the intact skull was not there. So the old Egyptians used to take the internal organs, put them in certain pots together with the deceased, so that when he wakes up in the afterlife, he will find his organs. So they would find the liver, the lung that was taken through incision in the body. But how did the pharaohs took the brain out of the skull? They found that the Egyptians knew the transnasal, transsphenoidal route, and they used to suck the brain from it and put it in a pot. So the first people who did transnasal are the Egyptians. And then we have Harvey Cushing, pioneer and father of neurosurgery, who did his first transsphenoidal in 1909 at Harvard University. This is him operating, and you can see this picture shows how things were in theater. His pupil was Norman Dott, a British surgeon who joined him for training for pituitary surgery. And this is Norman Dott, the big man. This was Norman Dott, and this is Harvey Cushing. And Dott sent his information to David Utley from England at Kingston-Morley, and David Utley really gave it to me. So it's a chain of people transmitting information from one generation to the other. This is Gerard Goyer from France. He revived the transsphenoidal in France. And this is Julius Hardy from Montreal, Canada, who again started in a big way the transnasal approach. One of his associates was Charlie Wilson. He's a Red Indian American who stayed working till the age of 85. He has done 3,500 pituitary adenomas. Edward Lowe's, working at Harvard, has done 5,500 transsphenoidal operations. Ed is a friend of Jordan, a friend of my family, and I'm proud to be associated with them. Rudolf Falbusch from Germany, Erlangen, is another giant of pituitary surgery. And here we are here in Amman, Jordan, and in Bulgaria, together in a conference. And the next man is this man, who is Engelbert Knosp from Austria, from Vienna, who I will come to later on to show what his contributions are. And here we are in Vienna. His wife and daughter took good care of me and my wife when we were there. Another person is Nelson Oseko. Nelson is Nigerian, Muslim, working in Atlanta, Georgia. He's famous for his pituitary contribution papers and so on. He's now currently the president or the chair editor of the CNS journal. And we are together members of this elite group of the World Federation. You may think here I'm gambling, I'm not. And I'm not drinking, this is not necessary. I'm not drinking. This was taken in New Orleans, and in New Orleans, they have arranged for us a fake casino so that you will go there and play with fake money so that you will have the feeling of how to lose. This is with Ed Lowe's. This is ISBS. What does that mean? International Society of Pituitary Surgery. So pituitary has a society, and I'm proud to be part of that society. And this is myself with Ed Lowe's, his wife, and my wife, Nelson Oseko. And here we're on a boat trip with his wife. Another group of people that have made their impact on pituitary surgery are the endoscopists, because nowadays pituitary surgery is very, very amenable for endoscopy. Charles II from Australia, Amin Kassam from Chad, but living in New York now. Karl Schneiderman, Paul Gardner, Michael Gabb from Germany, Theodore Schwartz from New York, all are famous endoscopists, and this is Fred Gentili from Canada. Here we are on a boat trip in Sharm el-Sheikh. So these are the endoscopists with their endoscope, various directions, 30 degree, 45, 0, and so on and so forth. So back to the title, giant, invasive. What do we mean by giant, and what do we mean by invasive? Pituitary adenomas are classified according to the size. Microadenoma means less than 1 centimeter in diameter, 10 millimeter or 1 centimeter in diameter. Macroadenomas, more than 1. 1 to 2 is regarded as small. 2 to 3 regarded as medium. 3 to 4 considered as large. More than 4 are called giant. And tonight we are going to present these giant pituitary adenomas. This paper from India, 2013. The title is, can it grow bigger than this? So for them, this is the ultimate. So as a patriotic Jordanian, I thought I should not miss that, and I sent them some of these pictures in my cases. So it can grow much, much bigger. And I call these pituitaries, I call this one in the middle, I called it Mickey Mouse, because it looks like Mickey Mouse. And this one looks like octopus. So I gave them some names. But they are really frightening. These are my cases. Look at this one. So we know giant is really giant, for more than 4 centimeters. What is the percentage of pituitary adenomas being giant? 1 to 10%. Some series 1%, some series 10%. What's the prognosis? Long-term prognosis of large and invasive pituitary adenomas, 2 out of 19 patients were alive after 12 years. That was published in 1986. So it was dismal prognosis for those giant pituitary adenomas. Another paper in 1990 occult invasive pituitary adenomas predisposing to fatal bacterial meningitis because they destroy the skull base and they have opening into the sinuses, and patients develop meningitis. That's 1990. And then more recently, for Martini, 2007, gave us a little bit of optimistic approach. He said that 5-year recurrence-free survival rate is 90%. So really they can go and grow in a very big way like this, down to the nasal sinuses, to the frontal lobe, up, causing this, everybody knows this, hourglass constriction or snowman appearance. But they can go retrocellular like this here, and they can go to the temporal lobe like this. Please.
Whose fault is it, doctors or the patient?
Both.
This to go that big?
The largest series of giant pituitary adenomas, I have it, and the Indians have it. So we compete who has the largest series, but I have the largest size, they have the largest number. And the reason is the fault of the patient and the doctors. We, in this part of the world, in the Middle East, in Jordan, in the Arab countries, in Asia, people stopped examining patients. The doctors stopped examining patients, stopped taking history and do physical examination. They just rush for certain one pathology and just go on. And of course, the mistake of doctors. We are producing lots and lots of doctors who should not be doctors. We are giving them certificate to kill and not to practice medicine. I'm sorry to say that. So, this paper from Italy, 2014, about the intrigue of giant adenomas. It is a true surgical challenge. And this paper from USA, 2019, giant pituitary adenomas with inferior petrosal sinus, jugular foramen, and hypoglossal canal extensions. So they have extended here into the hypoglossal canal, into jugular foramen. So please stop thinking of pituitary adenomas as benign lesions. They can be really bad. White and Warren back in 1945 classified these extensions. They said, well, they will go up to the hypothalamus, to the frontal lobe, to the nasal sinuses. They go to the posterior fossa, temporal, or to the cavernous sinus. And then came Hardy and Wilson, which I mentioned to you, Julius Hardy and Wilson, the Red Indian American, a very famous giant in America. He died actually recently. Hardy and Wilson classified this into grade 0, A, B, C, D, according to this kind of classification. So they look into, is this in the cella, or going up the cella, reaching to the third ventricle, or reaching to the laterally, and so on. Point of warning that extension to the cavernous sinus does not always represent invasiveness, because when the pituitary enlarges, you can push the medial wall of the cavernous sinus without invading it. There's a thin wall there. So not all giant ones are going to the cavernous sinus. So this man, Engelbert Knosp, which I mentioned from Austria, the man who took good care of me and my family in Vienna, he said, well, let's draw these lines. He looks at the carotid artery in the cavernous sinus, he looked at the carotid artery in the supracellular cistern, and he drew this line to the medial edge, this line in the outer edge, and this line in the middle. And he said, well, if the tumor crosses this way or this way or this way, this is invasion of the cavernous sinus, which is really a very good type of classification. So this is the principle. And look at this here. The tumor has gone between the two carotid segments. So this is definite invasion, or in this way, definite invasion, or this way, definite invasion. Examples of these, pituitary adenoma going this way, so it is going into this part. Here it is surrounding the carotid, and here it is underneath the carotid. So this is a very good example of to think of the invasiveness of these adenomas. So now we're talking about invasiveness, not only the size, but the invasiveness. Sinha and Sharma from India, they published this paper in the British Journal of Neurosurgery 2010. They said, let's see which is common. What is the commonest type to produce giant adenomas? And they found that the non-functioning constitute 55%, which makes logic, because non-functioning will not give you hormonal disturbances as prolactinoma, for example, so you may miss it. But look at this here, growth hormone and others are about 20%. So even the secreting ones can get large. And the astonishing ones are really growth hormone because you will have acromegalic features. So how did you miss that? That's why Dr. Junaid, we say it is a fault of the patient, fault of his family, fault of the doctors, fault of the Minister of Health in that country, and fault of the commander of that country. So giant prolactinomas, they shouldn't actually get giant because they will give you symptoms. The galactorrhea in females and the sexual disturbances in males are there. So how did it go to this size? Very large. And this is by Coleman Post, who's a famous neurosurgeon in New York. How do they present? The most common presentation is visual, which is expected because they will go up to the visual apparatus. Headache, hormonal deficits, apoplexy, and cranial nerve deficits. These are the common presentations. If you remember the optic pathways, how the optic nerves join the chiasm, the tracts going this way, the Myers loop, and so on. And this here is the cell lateral sequence of the tumor, which produce typically a bitemporal hemianopia. But is this right? Yes, most of the cases will give you this bitemporal hemianopia. But be prepared for any kind of pituitary adenoma associated with different kinds of visual field defects. Because the way they grow, it's not necessarily in the middle, they can go anyway. So you may get different kinds of visual defects. So they are either functional or non-functional. Non-functional, non-functional. Functional, according to the type of secretion of the hormone, prolactin, growth hormone, ACTH, TSH, FSH, LH, and so on. Please. Sometimes they are, sometimes not. And I will show you some video films that will give you a clue. But sometimes they are not capsulated. So males and the non-functioning will present with deficiency testosterone, and females it's luteinizing hormones. Both sexes will have hypothyroidism and adrenal insufficiency. What about pituitary apoplexy? They can present with pituitary apoplexy. What does that mean? Apoplexy in the minds of people is hemorrhage. No. Apoplexy could be infarction, could be hemorrhagic infarction, or could be pure hemorrhage. So not necessarily to see blood in the pituitary to diagnose pituitary apoplexy. It could be infarction. The majority of apoplexy occur in the large non-functioning. The minority occurs in non-secreting. And the notorious one is prolactin, because when you give them prolactin agonist, and then they will go and have this kind of apoplexy. About 16 to 18% of apoplexy happens in prolactinomas. Very nice paper, Apoplexy of Pituitary Adenomas, The Perfect Storm. There was a movie called Perfect Storm, if you have seen it, about this huge waves taking this ship away. This is Perfect Storm, the apoplexy. It's a medical and surgical emergency, and in some cases it can end in blindness or loss of life if you are not careful. They present like subarachnoid hemorrhage, like meningitis. So timing of surgery is very, very important. This is top emergency, medical and surgical. They can present with cranial nerves. This paper from New Zealand, from New England Journal of Medicine, about this patient presenting with third nerve palsy because the tumor grew this way in the roof of the cavernous sinus, where the third nerve is. I thought of showing you my cases. This is a lady from Sudan, presented with third nerve. Huge, giant pituitary adenoma. This patient from Iraq with this sixth nerve palsy. And this Jordanian man presented with third and second nerve palsy. Ptosis, and he is now looking to the left. The eye doesn't go there, so he has second nerve palsy. Second nerve palsy, third nerve palsy. They can present with hydrocephalus because they obstruct the CSF pathways. A man also from Sudan with this giant who presented to me with hydrocephalus. I do not put shunt. A good shunt is no shunt. Shunt is obsolete in the whole world. Still, it is done here every day. Revision of shunt, revision of shunt, revision of shunt. So the resident is graduated and he takes a certificate to practice, but the only operation he can do is shunt and revision of shunt. I'm sorry to say that, but this is a fact. So we spoke about the giant size. Let's speak about the invasiveness. How can we tell that this adenoma is invasive? Oh. Ahmed. So you can look at the invasiveness. You can see it in the images. You can see it during surgery, or you can see it from the histological specimen that you will send to the pathology lab. What about this? This is radiologically invasive. Cavernous sinus is very much invaded all the way. I call this the banana split. It looks like a banana split, actually. What about histopathology? When you do histopathology, the histopathologist will tell you whether this is typical adenoma, or whether it is invasive adenoma, or whether it is carcinomatous. By the way, the number of carcinoma in pituitary is very, very, very rare. It does not reach the figure 100 in the whole literature of medicine. So when the histopathologist, and I'm taking here over from Dr. Abu Farsakh, he's away in Oman. These are his slides, actually, from my cases. He would show you this as a dural invasion, tumor inside the dura. He would show you this, a tumor in the nasopharynx. He will show you this, brain invasion. Look at this, very distinct brain invasion. Brain invasion, Marwan, means that they are not capsulated, right? What are the things that correlate with the aggressiveness? If the histopathologist found atypical cells, this is very atypical cell, or find high mitotic figure, or if it is positive to CAM 5.2, or positive to chromogranin, or positive to P53, and when they have high Ki67 index. So these are indicators that are dealing with invasive adenoma. Please note that size is not related to the invasiveness. You may find a microadenoma which is invasive. But here we are presenting the giant and the invasive in one go. Myself and Dr. Farsakh, we collected the Ki67 index in 33 patients, and we found that a good number of them had high index. So high Ki67 index is an indicator of aggressiveness and invasiveness. We also looked at the P53, and we found that it was positive in 20 out of 26 patients. So that's an indication that it is invasive. This patient, giant, definitely more than 4 centimeters, before and after surgery. Immunostaining show Ki proliferation is 10%. P53 positive, chromogranin positive. So this size, invasiveness of the cavernous sinus radiologically, it is invasive, and the histopathology told us that it is invasive. Nobody at all in the whole world is still using acidophilic and basophilic. This belongs to the past, to the old ages. No more, no one speaks about acidophilic and basophilic. So you will find things like this, sparsely granulated prolactinoma. And when you go to the Pituitary Society meeting, you understand this. No one speaks about acidophilic basophilic. It belongs to the past. Densely granulated. Densely granulated growth hormone, sparsely granulated, mixed. Acidophilic stem cell adenoma, this is a specific type. Corticotrophic adenoma, and so on. Crux cell adenoma. Crux is very important. Crux changes. So things are different, and people have to raise to the changes that are happening in the pituitary histology. Carcinoma, as I said, is extremely rare. not more than 100 cases in the whole literature for the whole medicine. When you are doing surgery, you can tell that it is invasive. These are my cases. Here I'm showing the carotid artery, anterior cerebral, middle cerebral, and the tumor is embedded in the wall of the carotid artery. So this is definite evidence of invasion. One patient of mine, 47 patient, with this tumor, giant tumor, operated upon him. This is the end result. And when I operated, this is the A1, A2, A1, A2, anterior cerebral, and this is the anterior communicating. And this tumor was sitting inside the wall of the vessel. So this is definite evidence of invasion. And this was the final result when we removed this pituitary. You can see the basilar artery, the superior cerebral artery, posterior cerebral artery, and third nerve. So this was his diagnosis. Ki very high, 7%, P53 positive. The growth hormone 30% of the cells are positive, and so on. Another patient with this giant pituitary adenoma before surgery and after. Of course, I took it completely except that part within the cavernous sinus. You don't go there for these pituitary tumor invading the cavernous sinus. You can't take them out and you'll get complications. So again, here you'll find that it was invading the blood vessels, and the histology was confirmative. There was a brain invasion. And again, I'll go back to this Marwan. You can see that it is not capsulated at all. It is just loose necrotic tissue in the subarachnoid space. And there was a brain invasion. So here, the radiology, the operative finding, and the histopathology finding, they confirm that this is invasive giant adenoma. When we see pituitary adenoma or see a cellular lesion, people think of only three: meningioma, pituitary adenoma, craniopharyngioma. It's wrong, because differential diagnosis is so wide, and the radiologist should know this and give us a clue about what does he think this is. He would say, I don't think this is a craniopharyngioma because of this and that. I don't think this is pituitary adenoma because of this and that. I think it is out of 1 out of 3 or 5, so on and so forth. Atypical meningioma. I don't think any one of you would not think that this is a pituitary adenoma. It was atypical meningioma. This is the proof. This is the histology report. Clivus chordoma, occupying the whole cell. Again, patient of mine, 58 years. Again, patient of mine, plasmacytoma, taking the whole cell and clivus. Osteoma, taking the same place of the pituitary. This is a neuroblastoma or factory glioma. Sinonasal carcinoma in this Syrian lady with this tumor. He came to me as pituitary. It was sinonasal carcinoma. Metastasis. How come? Metastasis is happening in the pituitary? Yes. It's just because you don't think about it doesn't mean that it is not there. Because you don't want to think about it. You see abdominal pain, you say, oh, this is appendix or gastroenteritis. For goodness sake, there are 100 diagnoses that you should entertain. And that's why our doctors are given those certificates together. Optic chiasma glioma, a patient of mine, young child with this optic nerve glioma. Immature teratoma, this 6-year-old girl from Bahrain with this tumor. Craniopharyngioma, and I have larger than this. This is the solid part, this is the cystic part. So what's the management of these giant adenomas? Please, yes?
Now, I'm really fortunate to be working closely with Professor SBEIH just to illustrate this point. Now, these are actual cases where the histology was actually proven because the surgery was done properly. In what happens in the real world is that you bury the evidence by radiotherapy without bothering to know what on earth was going on. Oh, it looks like pituitary adenoma, so why bother radiate it and forget about it, particularly if it's not secretory. Now, this is what happens. If you deal with this improperly in the first round, you're going to be doomed by a course of recurrent meningiomas in the same site, where surgery would be much more difficult on the relapse. Now, missing plasmacytoma because it was radiated and improved on radiotherapy would be really a crime. It is true that plasmacytoma, the standard treatment is going to be radiotherapy, but we only term them as plasmacytoma if there's no evidence of plasma cell disorder in the body. That is, there's no osteolytic lesions, the bone marrow is negative, there's no SPEP is negative, UPEP is negative, etc. So the pathologist, when he gets the specimen, will say, I see plasma cells, please correlate to rule out multiple myeloma. There's no differentiating pathologically between plasmacytoma and multiple myeloma. The differentiation is purely clinical. And missing a multiple myeloma or plasmacytoma because nobody bothered to ask about it is another crime. Now, we continue talking about this in metastases, and this lady, for example, if she's a woman, or this gentleman, if he's a man, would get surgery or radiotherapy because nobody bothered to examine the breast or the testicle or the axilla, etc. And they would have been spared. And I cannot tell you how many times you get these middle-aged ladies because nobody bothered to examine the breast, and they actually had brain mets. And yes, this might be the only site of metastasis, and we see this only too often, unfortunately. Immature teratoma, where even with the brain involvement, they would be cured, treated with curative intent with chemotherapy alone, post-surgery. Craniopharyngioma with the approaches is quite similar to this. These are actual cases. And Professor SBEIH has such a huge series that we can document the variation with which these can masquerade as pitch adenomas. In real life, most of the evidence is buried by radiotherapy, and this evidence goes to the grave with the patient.
Thank you. Those who don't know Dr. Ala Gassi is a hematologist oncologist, and he's one of our favorites. So what's the treatment of these giant pituitary adenomas? Sometimes the patient's condition warrants observation. If there is medical therapy, like he has hypothyroidism or hypopituitarism, you have to give him medical therapy. There is surgery plus minus medications, and there is the adjuvant radiotherapy. The medications that one uses for the prolactinomas, dopamine agonists, and for growth hormone are somatostatin. Recently, there has been a call about use of temozolomide for these tumors, but this is not gaining that much acceptance. Yeah. So we come to surgery. Surgery is really challenging. Complication rate is high. Gross total resection is difficult. Gross total means 90 to 99 to 100% excision. Near total is 70 to 90. Subtotal is less than 70. So these cases, you cannot achieve radical excision. So you have to go for as much as excision as you can. But don't take a specimen and send them for radiotherapy. It is as criminal as putting a shunt. Anatomy, you have to know the anatomy well there. The relationship there are magnificent. This is the pituitary, this is the stalk, this is covered by diaphragma ocelli. This is the curve on one side, and the roof of the cavernous sinus. The olfactory, the optic nerves. Here's the still communicating with the third nerve, basilar artery with its bifurcation, perforators. Cavernous sinus is here and there. So you have to master this anatomy if you want to do this surgery. What our people here are doing in Asia and the Middle East, take a biopsy and send for the therapy, simply because they don't know the anatomy. Again, here the position of the ophthalmic artery and the underbelly of the optic nerve. Look at this here. You may easily damage that. And here are the superior hypophyseal artery going for the blood supply of the optic chiasm. Surgical approaches are many. You can do it transcranial, you can do it transfemoidal. If you want to do it transfemoidal, either you are using the microscope or the endoscope. This is the transnasal, whether you are using an endoscope or microscope, just the same. And when you look at the surgical approaches, this is Vinco-Dillon's. from Ljubljana, Slovenia. 210 giant adenomas, all they were done transcranial. 115 out of 18 were done by a transnasal. So people differ in their approaches. 80 out of 95 were done by a transsphenoidal, and so on. So people would use different approaches according to their expertise. And this is a published surgical series. And this is Lindsay Simon from Queen Square. This is Hardy, and so on. Dollins, Ali Krisht from Little Rock, Atul Goel from India, Murchini from Italy. And this is the success rates of total removal. Look at this. Total removal was only 15%. They are difficult, they are challenging. And if somebody would say size doesn't matter, size does matter in every aspect. Then pituitary adenomas by Atul Goel, that was 2003. Again, he is one of the people who hoard a good number of these giant adenomas. And whenever we meet in a meeting, we start the fight who has got the largest series. That was his paper in 2003, and this is his paper in 2013 in the World of Neurosurgery, the challenge of giant pituitary. It is a challenge, no doubt about that. Endoscopy is coming strong in the treatment of these cases, but endoscopy, if you are in the midline, it's okay, but if the tumor goes laterally, you cannot reach it. So the narrow corridor of transsphenoidal does not allow you the paracellular extension. So whenever there is a paracellular extension, a retrocellular extension, you cannot do it by endoscope or microscope. You have to do it transcranial. This is a paper, management of large and giant. Okay, but this is straight supracellular. Here with some extension. They cannot remove this. Same here. This is within the cell, so it can be removed. Endoscopic Indonesia. Again, from United States, endoscopic for large and giant. But you can see the cases they are presenting are within the cell and supracellular. They are not paracellular. So I totally agree. This was paper by Amir Dahshati from Canada. And you can see that all these cases, I say, if they are cellular, supracellular, you can use endoscope. Once they are paracellular, you can't. And then another paper from the States by Theodore Schwartz and his Indian counterpart, T. Vijay Anand. They work together. This is the idea. This is teamwork. I, with Dr. Mahmoud Asad, do our cases transnasally all the time. It's not me who's doing all the job because he knows much more than I. So a combination of people would give you the best results. Another paper here, endoscopic transnasal. Again, endoscopy means that the tumor is cellular, supracellular, no lateral extension. Sometimes you do combined, like abdominoperineal surgery. Combined. This is paper about combined. This is by Nelson Wasiko, which I mentioned to you. This is him operating in his theater in Atlanta, Georgia. And here again, combined transsphenoidal and endoscopy. Microscopic and endoscopic. Please. Yes. This paper is about combined endoscopic and microscopic. But there are cases with combined endoscopy and craniotomy. I will come to that. This is one of them. I think I don't have it here. I had it before, but they use both craniotomy and endonasal, and I used it once in my life. Of course it does. This was Dr. Mahmoud Asad, my ENT counterpart, and I'm proud to have associated with him for the last 30 years or so.
Are you trying to imply that you're counseling them?
Okay, what about radiation? Is it good? Don't use radiation as upfront. Don't make the mistake of taking a biopsy and send for radiotherapy. This is a crime against humanity. It's exactly like doing the shunt or putting screws and plate for non-indicated cervical disc So gamma surgery can be used, but not as upfront. Now coming to my personal series of these giant pituitary adenomas. Between 85, when I came back from England, to 2018, I always miss the last 2 years because I do not present any case less than 2 years. It's not good. You have to have 2 years at least to follow up. Of pituitary adenomas, I have 910 patients, pituitary adenomas, which is much less than the 5,000 of Idlos, but it is a big number. Out of these, I had 86 patients with giant adenomas. So it's almost 10%. Mostly males, and mostly were non-functioning, non-secretory. But they were prolactin secreting, they were ACTH, they were metronome. Somebody asked, why did you operate on prolactin? It's because they failed medical treatment and they had almost blindness. So they are not responding to medical treatment and their vision is failing. So you go and operate. But the first and foremost treatment for prolactinoma is a dopamine agonist, even if it is giant. The clinical presentation in my cases were mostly again visual, but of course the others are there. And we document the visual fields before and after surgery. This is, sorry, where am I? This is one of my patients, JT from Iraq, with this visual field defect before surgery, and this is after. So this open up, and this is opening up. That was February to April. We do full histological assessment of immunostaining, prolactin, growth hormone, ACTH, FSH, synoptophin, cytokeratin, B-catenin, NSE, CD68, S100, Ki67, P53, CAM52, and chromogranin. All are done routinely. That's why I'm against the so-called package, which is really another crime, which is practiced in this part of the world. You take a patient as a package. When you take him as a package, you will not do CBC for him, you will not do ECG, you will not do this from the lab. And even the insurance company will prevent you from going into this elaboration. I looked at my cases and said, where did they go? These are giant ones, but which structures did they invade? And I found the cavernous sinus and paranasal sinuses are good numbers, but they can go anywhere. Let me take you through these cases. Cavernous sinus invasion, look at this. The octopus here, the octopus there. None of these cases I'm presenting is from outside my series. Paranasal sinuses, pituitary adenoma going to the maxillary sinus. They go to the ethmoid, they go to the sphenoid, they go to the orbit. They go anywhere. In recurrence? I'll come to that. Clivus, look at this, completely destroying the clivus. And this, no clivus, it's completely destroyed. Look at this, Mickey Mouse, frontal lobe invasion. This is the mystery of all. Tumor here in the parieto-occipital region, and it was coming from the pituitary. Temporal lobe. Look at this, going to the temporal lobe cavernous sinus. And this is subtemporal. And this is destroying the petrous. This is going into the hypothalamus. This is going to the thalamus. So when we say giant, they are really giant. Look at this midbrain invasion here. Midbrain is totally invaded. Again, sending them for radiotherapy is a crime. Posterior fossa, that most of the tumor is in the posterior fossa. Here it's sitting in the cerebellopontine angle, prepontine cistern. They can go to the lateral ventricle, totally inside the lateral ventricle, loose tissue, not capsulated. Third ventricle. They can invade the cranial nerves. Here they are invading the optic nerve. Here they are invading the third nerve. The third nerve is just exactly here in the roof of the cavernous sinus. Here it is invading the trigeminal nerve. Here it is invading the abducens nerve. So they can invade cranial nerves. We said about the midbrain and the posterior fossa. And of course, they can invade the blood vessels. I mean, radiologically, you can see here, this vessel is narrowed, not because it is compressed, because the tumor is going into the wall of that blood vessel, like I showed you in the pictures before. So indication for surgery, neurological deterioration in spite of medical therapy. Prolactinoma having medical treatment, in spite of that, it's growing, failing vision, and so on. And your aim is to achieve gross total resection. Because your aim is to improve the vision, and then you minimize the tumor mass. So when you send them for radiotherapy, they will have some benefits. But to send a tumor with a giant mountain of tumor tissue to the radiotherapy, it's a crime from the surgeon who sent it. It is a crime on behalf of the radiotherapist who's doing radiotherapy. I've used the different approaches. I used the transnasal for giant ones in 17 cases, transcranial 68, and then one I used, Mahmoud Asad, I used this, which is transnasal and craniotomy at the same time, myself and Dr. Sartawi. Different approaches were used. I love this approach, which is the interhemispheric. And I was blessed that most of the patients had visual symptoms. 42 out of 54 patients improved their vision after surgery. Did I have morbidity? Of course. I would not be standing in front of you and have done these almost 1,000 cases without morbidity. The one who does not have morbidity is the one who's sitting home, just reading books, or he has done 1 or 2 cases and there was no complication. They say, I have 0 complications, nonsense. So I have different complications related to the surgery. Did I have any mortality? Yes. I had 2 deaths in 86 patients. Let me share it with you. This was a patient from Iraq with this very invasive adenoma. And when we did the surgery, she ended with CSF leak because we removed the tumor from places which was plugged by the tumor. Once you remove it, the pathway is open for CSF to go out and for organism to come in. She went back to her country, Iraq, and that's the picture they sent me after 1 month with free air inside the cranial cavity. They could not bring her back to Jordan, so she died in Iraq. Second patient is a Jordanian lady who had previous surgery. So we're doing a current case. It was ACTH. I did beautiful surgery, beautiful results, but she died on the 8th postoperative day because of pulmonary embolism. Please.
Stressing the importance of not forgetting DVT complexes in patients. And in the field of neurosurgery, the problem is that the risk of bleeding is higher, which limits what we can. And this is why we use pneumatic compression devices in both lower extremities, post-operatively until we can use another level. And let me stress here the inadequacy of using elastic stockings. Elastic stockings use should be condemned with the strongest, in the strongest way possible. What elastic stockings do post-operatively, they actually would cause a tourniquet effect. If you closely look at an elastic stocking on one of the patients, even the good quality ones, and which would increase the stasis. So if you cannot use unfractionated heparin or fractionated heparin, you can use pneumatic compression devices above and below the knee, not below the knee. Tightly fit, not loosely fit, so that they would be useless. You can prevent lots of disasters there.
Thank you. But if you are taking the case as a package, you would not even think
yes, of course.
Compression
devices are expensive. Particularly when they're above the knee.
Yes.
And
okay. Did I use any drugs or radiation after? Yes. I continued with drug therapy, for example, for prolactinoma. I use the gamma knife. People say, oh, you are against it. I'm not against gamma knife. Gamma knife is a good tool, but it has to be in the hands of people who can do the surgery. If they are put in the hands of mediocre surgeons who cannot do surgery, they will treat everything across the board with gamma knife. So I use the gamma knife. I use radiotherapy post-operative. I reoperated on 6 This is the answer to you, Marwan. 6 cases were recurrent and I had to operate on them. This is the first gamma knife in the Middle East, 1996, and this is me treating the first case and the second case and the 12th case. So gamma knife is mine, but I believe from the very beginning that a fool with a tool is still a fool. So don't be affected by people using this, because sometimes they don't know how to do the surgery, so they will do everything with the gamma knife. I treated 12 patients, and this is their definition, non-secretory in 9. An example of this, after surgery, still functioning, so we treated her with gamma knife. So I do refer cases for gamma knife. I'm not against gamma knife. I'm against the mediocre surgeons, mediocre radiotherapists who use it for anything and everything. These are not even doctors. They are button pushers. They just push a button to take 8,000 and 10,000 JD or dollars. They have to be condemned because they are criminal. This is the gamma knife effect. One case of mine had decrease in volume, stable volume in 10, increased volume in 1. External beam was also used for many cases. Complications of radiation, decreased cognitive functions in 3, decreased vision in 2, temporal necrosis in 1. Let me show you some cases, and then we'll be finished. This is a giant pituitary adenoma before surgery and after with radiotherapy. And this is the one of the giants, and this is the one where I left the part within the cavernous sinus. But look at the after radiotherapy, it is much less. This is a story on his own. 37-year-old male patient. If you can read here, it says Hadassah Hospital. Hadassah is in Jerusalem. It's with the Israelis, and this patient had his MRI there. And look at his prolactin. This is diluted specimen. 17,823 micro-international units. So we did surgery for him. I always mention that he has a coffee shop in Jerusalem, and whenever he comes from Jerusalem, he brings some coffee from Jerusalem, and I kiss the back before I open it, because it is from Jerusalem. So this is the 1-year follow-up. This is real cases. This is real documented cases. It is not fiction. And this is 5 years follow-up, and this is 9 years. No recurrence. Another patient who had 2 surgeries. First surgery with the DST at St. Elsewhere. Second surgery in 2000, transcranial and transnasal, and he was left with this tumor. He came from Syria. So what should you do? Operate again. So we did the surgery and gave him radiotherapy, but we did a good surgery. And this is for up 7 years.
That was regrowth.
How was?
That was regrowth. That was actually regrowth.
Yes, it was not a regrowth means that somebody has removed it. They did not. They just took a biopsy and they sent them for. This is the crime we're talking about. But people don't think about this because they don't know. Again, this patient with this phenomenal prolactin level, the one which I told you is in the parieto-occipital region. Imagine this is a prolactinoma. Here it is, here it is, here it is. And this is after surgery for 4 years follow-up. Another patient also with this first surgery and second surgery, bad surgeries, I must say. When you ask people how many craniotomies, I have done 150 craniotomies, but they are baseless, they are useless. So destruction is complete here. And this is preoperative, this is immediate post-operative, follow-up 6 years, 2 years and 6 years. Apoplexy, what is the percentage of apoplexy in my cases? This is one of them. Remember that apoplexy does not mean hemorrhage, it means sometimes infarction. But here, in this case, it is hemorrhage, and that's why we have a fluid level. 46-year-old man. You can see another one with this a giant adenoma with pituitary apoplexy. This man follow up. And this young man of 34, when you look at him, he has no beard, he had pan-hypopituitarism. You say, how did his family miss that? How did he miss that? That there's no beard coming out, no hair on his body. The doctors who had seen him, I have fair vision, they would give him glasses and eye drops. So it is a mixture, Dr. Junaid, of ignorance by the patient, his family, and the doctors in that country. Look at this. When we say giant, it is giant. Before and after surgery. Another patient with this giant pituitary adenoma with apoplexy, before and after surgery. Same thing here, before surgery and after surgery. Let's show you 3 quick videos so that you have the taste of the thing we're talking about, and then we'll finish. It's really quick videos. Here, I'm just trying to show you, and this is for you, Marwan. You see, it's not capsulated. It's loose tissue sitting in the subarachnoid space. This is optic nerve, this is the carotid. This is middle cerebral. So I'm working here between the carotid, middle cerebral, and look at this, tumor is attached to the wall. Trying to remove it, you can't, because it is inside the wall. Here is third nerve being invaded by the tumor. Okay, next one. Here it is capsulated. So you actually take it outside like this. And these are the branches from the anterior cerebrum, A1. And this is the one I told you. When I came at the anterior communicating, this is anterior communicating. Tumor is between the two A2s and below them. And here I have to be careful about the perforators, especially the recurrent artery of Hubner, which supplies the internal capsule, damage of which will cause hemiplegia. So well encapsulated, but in this part here, it is attached and buried into the wall of the, so I have to use the scissor to cut. It is not separable. It is inside the wall of the arch. Okay. This is a 3D, but I think for the time's sake, we'll just put the 2D instead of giving you the goggles and so on and so forth. And we really need 3 screens because 1 screen is not enough. So this is the approach I like. Here I'm cutting the most anterior part of the superior sagittal sinus so that I'll gain access into the interhemispheric space. I always preserve the olfactory tracts because olfaction to me and to the patient is very important. So here is the olfactory tract on this side, the olfactory tract on that side, and this is the arachnoid on the optic nerve and cares. So this is the tumor between the 2 optic nerves. I cauterize the capsule, I incise, start removing it. But this is everywhere, so you have to go into different compartments. Sparing the arteries that go into the optic apparatus is very important, otherwise the patient will end in blindness. Removing of the capsule. People say, you don't remove the capsule. You have to remove the capsule. Capsule contains a lot of a tumor. So the notion that people, consultants teaching to their residents, you don't have to remove the capsule is nonsense. Where did they get that from? I don't know. Maybe sitting at home watching TV. Gabriel came down on them and gave them this new neurosurgical finding. So here, now we go laterally between the optic nerve and the carotid artery. Tumor is still there. Huge tumor. It's not enough to take a biopsy. It's a crime, which happens every minute of the day, every month, every year in this part of the world. And my duty is to point that out. So here I'm cutting the last piece of the tumor attached to the dorsum celli. And there in the depth you can see the basilar artery. Difficult surgery, challenging surgery, because it needs lots of anatomical knowledge, which most people don't have. I'm sorry, but they don't have. We are now removing the tumor inside the pituitary. Now we know that the tumor is invading the optic canal, so I have to open the optic canal. I'm cutting the dura on top of the optic of the anterior clinoid process and started to open the and drill the superior orbital fissure and the optic canal. It's a tedious surgery, takes long hours, but if you are not prepared for this, neurosurgery needs stamina physically and mentally. Yesterday we did the surgery that took, 15 hours. And here am I giving a lecture now because this is in neurosurgery. So there are no place for a Speedy Gonzalez, no place. So here I'm opening the dura around the optic nerve. Again, here any mistake, I would cause madness, but I have to do it. Opening the superior orbital fissure as we open the optic canal. Okay, we'll stop here. I hope I did not bother you, but the conclusion of my presentation is surgery aiming at a gross total resection. Gross total means 90 to 100%. Has important role to play, though no surgical cure is possible. You cannot surgically cure them, you cannot remove it 100%. Surgery needs to be followed by complementary drug therapy or radiotherapy. And the radiation after surgery for these cases is very important. I want to finish with this. People ask me, how can you keep giving this lectures week after week for the last 27 years? I will quote Julius Hardy. I quote, "It's good to be a seeker, but sooner or later you have to be a finder. And then it is well to give what you have found as a gift into the world for whoever will accept it." Thank you very much. Any questions or comments, please?
The
youngest was a young boy of 8 who had, yes.
And how many less than 18?
A good number of them, but most of the patients are adults. Dr. Murtaki. Yes.
Now, this patient, you may have said you may do a surgery or you may just wait. But some of these patients, we break it down, we have down, and then what they say about local tumor, local tumor, which is no subsequential growth. Actually, maybe
okay, sure. Those surgeons who use radiosurgery are mukar neurosurgeons. They are, as you said, mediocre surgeons. And they have what we call jargon language. This is the jargon language. Jargon يعني أي كلام. 80% control, 85% control. What do you mean control? The tumor is the same, so the tumor is there. Yeah. Maybe that's the mindset. Any other questions, comments, please, Dr. Ahmed? Dr. Asad. Yes, I put it with the mortality, morbidity. I have 2 cases of permanent visual deterioration. 2 cases out of the 86. Nothing you can.
My comment is about all the
True. True. Absolutely.
Second thing is how to differentiate between basic carcinoma and basic adenoma and carcinoma. The only thing you have to look for is
But carcinoma opportunity is really very rare. Absolutely, yes. Any other questions and comments? If not, I thank you and we'll meet next week, inshallah. Thank you very much. Hello. Hello.
Hi, Dr. Sabeya, can you hear me?
Hello. Yes, I can hear you loud.
Thank you very much for a great presentation, multidisciplinary as usual. We have a question. Stuart, can you ask Dr. Sabeya the question, or do you want me to ask it? Okay, well, he texted me. He's a neurosurgeon from Ecuador. Stuart Portillo is his name. And he says, in cases of giant adenomas, have any protocol to operate first transcranial or endonasal or only transcranial?
Sure. As I said, depending on the radiological appearance, whether the tumor is cellular, supracellular, or with retrocellular or paracellular. If it is cellular, supracellular, this is a good case for transnasal, whether it is microscopic or endoscopic. But for those cases that are having retrocellular or paracellular, then craniotomy is the answer.
Very good. Okay, thank you very much. I'd like to introduce Musindo. Are you there? It's a neurosurgical resident from Mozambique in Africa. Hello, Musindo. Can you unmute and say hello to Dr. Sabeya? Go ahead. Go ahead.
Hello,
Hello.
I'm Musindo from Mozambique.
Yes, I can hear you.
Yeah, he just wanted, his connection's not great. So Dr. Sabeya, what's the topic next week?
Still, I did not decide, but I may go for the very funny histopathology diagnosis of pachymeningeal hypertrophy that presents like a tumor in the spine and in the cranium. So hypertrophic pachymeningitis in the cranium and in the spine.
Okay, very good. Thank you, doctor, and we'll see you next week.
See you next week. Thank you very much. Bye-bye.
Thank you. Okay, very good, Musindo. We're off the air now. We're stopped recording. I think it's great. I thank you for your support.
What?
Thank you for your support.
Oh, no. I am learning. I'm improving my English.
That's okay. Is French your main language?
No, my main language is Portuguese.
Oh, that's right. Portuguese. That's right. You mentioned that the country is very Portuguese.
Yes, it's Portuguese, our main language.
I always get Mozambique and Zimbabwe confused.
You're very,
It'll take time. It'll take time, but I'll learn.
now we are neighbor. We are neighbor. Mozambique and Zimbabwe, we are very close country.
Very, very close, right? All together.
Yes. Yes,
Okay.
yes, very
Yeah,
close.
I gotta get the map out and really get a good idea. Okay, there's a couple other people here. Let me introduce you to them. Musindo. Stuart, are you there? I'm going to unmute you, Stuart. He's had problems with his connection. He's in Ecuador, South America. Well,
Okay.
I guess you can't unmute. And Saad, do you want to talk, Saad? I guess not. Well, that's okay. Well, okay. Once again, thanks for your support, and I'll be seeing you the next time.
Next time, no problem. Thank you. Thank you too.
Okay. Bye-bye.
Goodbye. Goodbye.
Meeting.